I do full-time sleep medicine in both adults and children, and that's what I on a daily basis. Over a period of time, I found a couple things. One, that I was repeating a lot of the information over and over and over again, and two, I kind of ran into this issue that medications just don't really seem to work. People develop tolerance. I mean, everything is approved and during a study, but studies study a short period of time. They don't look at things over the long term many times.
Before we get started, I have a quick favor. I've been self-funding the Finding Genius podcast for 5 years now. I've done over 3,000 episodes, and as you can see on YouTube, we're up over 1 million views on the channel, which is fantastic. The next thing I really want to push on is to get up to 10,000 subscribers, because once we do, we'll be able to put a donate button, and we'll be able to solicit donations to help keep the podcast running and to also get the Finding Genius Foundation moving along. We have a big project studying anxiety, depression, and PTSD, and working on a product to help people overcome these problems, because I've seen them explode recently after the last 2 years of the whole virus situation. So if you would, please subscribe to the podcast. That would help us tremendously. Give us a thumbs up, and check in the description for Buy Me a Coffee. It's about $5. If you could buy me a coffee, I'd really appreciate it. It would help keep the channel going, and I love coffee. Thank you.
Forget frequently asked questions,
common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Jose Colon. He's a triple board-certified physician, which is amazing. What are the 3 board certifications in, Jose, by the way?
Yeah, thanks for having me. Pleasure to be here. And I'm originally board certified in neurology with special qualifications in child neurology. And I also did my sleep medicine training at Vanderbilt along with the neurology training. So I'm dual certified in that. And most recently, I picked up board certification through the American Board of Lifestyle Medicine. So the lifestyle medicine is my third board.
That's amazing. I mean, we all know how easy it is to become board certified. You just pick them up like, whatever you feel like, it seems like. It's amazing. Congrats to you for that's a lot of hard work. I know that. I mean, I don't know personally, but I mean, that's a lot of hard work. So that's great that you've done that.
It has been a lot of hard work over the years, but also at the same time, nothing in life is easy. Everything that you've worked for. Everything that our listeners have had, they've worked hard for as well. So, we all do important things.
Okay. And I know as part of the bio, you specialize in sleep disorders. You've authored a couple books, Sleep Diet, A Novel Approach to Insomnia, I guess a children's sleep book, The Magic Ice Cream Palace, and Sometimes I Dream for infant sleep. So you've been around the sleep world. You've done a lot there. What's your current focus and your current interest in the world of sleep? What fascinates you most right now?
Well, I do full-time sleep medicine in both adults and children, and that's what I do on a daily basis. Over a period of time, I found a couple things. One, that I was repeating a lot of the information over and over and over again, and two, I kind of ran into this issue that medications just don't really seem to work. People develop tolerance. I mean, everything is approved and during a study, but studies study a short period of time. They don't look at things over the long term many times. And having, as I said, that I found myself repeating myself multiple times, I said, why don't I accumulate information and I can put it in a book. And also having gone through the experience that medications didn't really seem to help over the long term, I'm like, all right, let me learn about as many non-pharmacologic treatments as we can. So I started learning about behavioral sleep medicine, and then started learning about hypnosis, mindfulness-based stress reduction, and my practice in sleep medicine is incorporating this integrative and holistic approach. And my books were made as creative. They're not like a set of instructions of, okay, this is what you do to go to sleep. No, they're actually interactive, fun books for both women with insomnia as well as children of any age, and kind of like a get sleep right the first time infant book. So a lot of passions in life that I've integrated together.
You do sleep medicine right now. What are some of the main things that you'll run into? What are really common sleep issues? And then maybe let's talk about some that are rare but impactful or interesting to you.
So one of the most common things that we do see is obstructive sleep apnea. Obstructive sleep apnea is difficulty with breathing in your sleep. How common is this? Males from 30 to 60 years of age have a 25% incidence of sleep apnea. It's pretty high if you consider that, asthma is 5% of the population. Well, sleep apnea can be 25%. And then after menopause and after 50 years of age, the incidence in males and females is about the same. So in the adult population, there's about 25% incidence of sleep apnea. And then in the pediatric population, we're learning a lot more about sleep disorders and the developing mind and ADHD. And what's interesting is 2% of children have obstructive sleep apnea, but anywhere from 10 to 20% can have something called primary snoring. So I see a lot of kids that are snoring, but not all of them have sleep apnea, kind of like the adult population. And of course, these are treated in different ways as well. So the first part of the question that you asked me is, what are some of the common things that we see? And that's some of the more common things that we see. We also do see insomnia. Insomnia, 30 to 40% of the population at one time is struggling with sleep. That's pretty high. And there's a number of reasons for this. Sometimes there's something called psychophysiological insomnia, and that means that some people have difficulty sleeping because something's bothering them, and what's bothering them is they're not asleep. So kind of like the harder people try to sleep, the more alert that they become. And those are some of the more common things. And then rare but important things, sometimes I do see nocturnal seizures. Other times I do see patients with narcolepsy or idiopathic hypersomnia, which are brain-based disorders of sleepiness, even though they're getting adequate sleep.
And what segment of the population, again, do you feel is probably most underserved by any kind of sleep medicine? Is it children? Is it adults with apnea? Is it, people with narcolepsy?
Well, I think equally throughout the board, a lot of these are underserved. So the vast majority of patients that actually have sleep apnea have yet to be diagnosed. They come to me when they got a colonoscopy done and they stop breathing at the table. Well, guess what? They didn't have it from the colonoscopy. They've had it for, a decade before that. And it wasn't until that event that brought them in. And likewise, in the pediatric population, we see a lot of underdiagnosis of sleep disordered breathing and narcolepsy. Narcolepsy in particular is pretty underdiagnosed. The average onset of symptoms is about 15 to 19 years of age, but many times people aren't diagnosed until after a decade later of having had these symptoms of sleepiness, and they're like, oh, well, you're depressed, you're having a sedating antidepressant. Well, you can see how that's not going to necessarily help. But yeah, that's some of the common and underserved things that we see.
So what are some of the places where advancements taking place in sleep medicine? Let me back it up. Is it that the technology is there to help people? It's just getting people to understand they need it and getting diagnosis on people, or is it that new technology is needed and what we have is not adequate for certain conditions like apnea, snoring, etc.?
Before we continue, I've been personally funding the Finding Genius podcast for 4.5 years now, which has led to 2,700 plus interviews of clinicians, researchers, scientists, CEOs, and other amazing people who are working to advance science and improve our lives and our world. Even though this podcast gets 100,000 plus downloads a month, we need your help to reach hundreds of thousands more worldwide. Please visit findinggeniuspodcast.com and click on Support Us. We have 3 levels of membership from $10 to $49 a month, including perks such as the ability to see ahead in our interview calendar and ask questions of upcoming guests, transcripts of podcasts you're interested in, the ability to request specific topics or guests, and more. Visit findinggeniuspodcast.com and click Support Us today. Now back to the show.
I mean, everything that you said is true. You've obviously researched this, so you're pretty well versed in this. If I can add to what you said is medical education actually isn't up to snuff with where it should be. For example, when I did my medical school training, I received one lecture on sleep apnea, and then I received a lecture on medications for sleep by a psychiatrist, and that was it. When I did my primary care residency, I got no lectures on sleep. And then I decided to become a child neurologist, and at Vanderbilt, the Department of Sleep Medicine was through the Department of Neurology, and that's the first exposure that I got of sleep. So, I loved it and ran with it, but the majority of the docs that are out there have not had any information about sleep. So I'm not saying that we're bad docs or anything like that. I'm just saying that the exposure hasn't been there for us to even think about. And people say, the mind cannot, the eye does not see what the mind does not know. And if you are taught these as possibilities, you're going to miss it.
So, at home, okay, so I know that diagnosis for apnea will happen either with a sleep study where you'll go to a lab, or they have home sleep study kits. What are you suggesting to patients, and why? Are you suggesting both, or one or the other, depending on their circumstance?
I have some suggestions that are important, but, equally as important as the consideration is what's the insurance company going to pay for, and many times the type of study that you get is dictated by the insurance. And what I'll say is that both of them may potentially give adequate information. The gold standard is a facility sleep study. Now, these home studies, it's the new rage. Everyone is talking about them. Everyone wants them. They come in saying that they want a home study. But what people don't understand is that they're not truly home sleep studies. They're home sleep apnea studies. And they were made for the sole purpose of detecting sleep apnea. The majority of these home studies actually don't look at brain activity, so they're not looking at sleep quality. They're not looking to see if you're getting into the stages of sleep. And another thing that people don't realize is that they're not as accurate as facility study can underestimate. So anyone who has had a home study, a home sleep apnea study, and it doesn't come back conclusive for sleep apnea, they actually, through the American Academy of Sleep Medicine, they do recommend that a facility study be done. Looking at disorders, other disorders such as nocturnal seizures or REM behavior disorder, restless legs, periodic limb movements of sleep, these are all things that you need a facility study that's looking at the brain activity as opposed to just a home study.
So the home study is good enough to get a C-Pap or oral appliance, or do you think that if insurance will pay for it, the lab sleep study is better?
So your first statement is correct, but let me add on to it. Your statement was a home study is good enough to get C-Pap or an oral appliance. Yes, that is true, however, they are not good enough to exclude a sleep apnea. So again, yes, they can diagnose sleep apnea, but if one comes back negative, then a facility study is indicated. My clinical experience, what I've seen several times, is that they underestimate, and they can underestimate by 10 points. And what do I mean by that? So if someone has difficulty breathing 5 times per hour, that's sleep apnea, something called an AHI or apnea hypopnea index. The name isn't important. The concept that I'm saying is that if someone has difficulty breathing 5 times per hour, that's sleep apnea. So I have seen these studies, they come back to me as saying, okay, negative at 3 times per hour. But then when we do a facility study, they could be off by 10, and I could see that they stop breathing 13 or 15 times per hour. So it's important that if one comes back negative, that a facility study is done afterwards.
And if someone comes back positive, does that mean that their apnea is pretty significant, or is it just the nature of home studies could be, off base for certain people, or is it only kept serious people?
So if they come back positive, they can diagnose it. So yeah. And, I tell them, look, you stop breathing this many times per hour, that's sleep apnea. Now, it might be more, okay? It might be more severe than what it currently is. than what the studies say. But yeah, so it is good enough to diagnose.
And what about snoring? Do people come to you and say, hey, I can't sleep in the bed with so-and-so, they're snoring my head off? And if so, is that always because of apnea, or is snoring itself something that can and should be treated?
So not all snoring is sleep apnea. Not everyone who has sleep apnea snores. And there are different types of sleep apnea as well. But snoring in an adult really is a very big sign that a patient may have sleep apnea. And even if it comes back negative for sleep apnea, the dental devices are great for snoring in someone who's negative for sleep apnea. I really advocate for them. I use one myself, and I notice an improvement in sleep quality. Snoring in a child, if you recall, 2% of children have sleep apnea, whereas 10 to 20% of children, almost 10 times more common, have primary snoring, which means that there's a vibration from snoring, but they don't actually have sleep apnea present. I hope that clarifies.
Yeah, have you seen cases where the person has apnea, but there's no audible snoring?
I see people all the time that they tell me that they don't snore, and we do a sleep study on them, and we do have microphones, and we are able to pick up audible snoring and sleep apnea being present. And then there's a different type of apnea called central apnea that the brain just doesn't take a breath, and you're not going to see snoring with that. That's more common in neurologic disorders or patients on opiates or patients with congestive heart failures.
Okay, all right, gotcha. So as someone that uses an oral appliance, tell me about your experience with it. Like, what did you find difficult about it? What did you notice, when you first used it versus later on?
So when I first used it, the very first night that I used it, I had like a lot more dream sleep, a lot more REM sleep. That's something that I noticed. One thing that was an adjustment is the very first night that you use it, your teeth kind of hurt the next morning, kind of like if you had braces. But anyone who's had braces will tell you your teeth don't hurt forever. There's an adjustment period, and it took a couple of days to adjust, and then now it's been a couple of years, and it's like nothing. But the biggest thing that I do notice is that sleep quality is a lot better.
So the theory of the oral appliance is to advance your jaw because during sleep does your jaw fall back? Or like, why wouldn't you have a sleep appliance that just keeps your jaw in its neutral, occlusion or bite position and not advance it? Why isn't that enough?
Yeah, so I have a great diagram that I show to my patients, but obviously can't do that on the podcast here. But trying to draw it out mentally, just kind of picture your airway, and part of what happens in sleep apnea is that the upper airway collapses, and in particular the base of the tongue collapses into the airspace. Now, just yourself, just kind of wiggle your jaw and move it forward. Advance the bottom part of your jaw forward, and you can see how that's bringing more space. And then I'll even do kind of like a demonstration with my patients where I say, okay, I'm going to make a snoring sound. Now I just made a snoring sound. Now I'm going to move my jaw forward. Now I'm going to try to make that sound. Now I'm not able to do that, and I have them kind of do that as well, and they're like, oh, okay, yeah, that makes sense.
Mm. So, but again, when you're sleeping, let's say you're sleeping on your back, which seems to be the worst position for apnea. Is it that the tongue is falling back, but the jaw position stays the same, or is the jaw itself, the lower jaw, relaxing backwards and downwards as well?
The airway collapses, the jaw relaxes, and the tongue collapses with the jaw collapsing. And then when you stabilize the jaw, you stabilize the airway.
Okay, so it may not be effective enough, but even if you put in an oral appliance and it just kept your mouth at neutral, and then you laid on your back and sleep, that would probably be a little bit better than the jaw falling back as well, a few millimeters, right?
Correct, and you can have the jaw at neutral, or you can advance it a little bit more. So either one of those are helpful.
Oh, so if you advance it, it's probably falling back to neutral anyway when you're laying down.
No, because it's advanced and it's set to a particular point that it doesn't come back, so it's locked.
Oh, it's anchored. It's the top. Okay, right into the top jaw. Got it.
The blade wood anchored. It's anchored forward. That's a great word.
Any difficulties with the oral appliance? I mean, is the mouthpiece open enough that it's easy to breathe through your mouth, or do you have to breathe through your nose to use it?
Yeah, you can breathe through your nose or through your mouth. And most people be able to do a combination.
Maybe would it make sense for someone to wear it for like, an hour, an hour a day at first to get used to it, and then wear it for the whole night, or just put it in and try to sleep with it the whole night the first night?
Just put it in and try to sleep with it. Let me, kind of answer the question a different way. Does it make sense to breathe in your sleep for just 1 hour or throughout the whole night? I'm not being sarcastic, but that's questions that people ask me, and then when you rephrase it that way, they're like, yeah, I guess it does make sense to breathe the whole night. People even ask me with the C-Pap, should I just use it for a couple hours? Well, I mean, how many hours in your sleep do you want to breathe? They're like, oh yeah, I guess throughout the whole night.
Yeah. Since you've been wearing one for years, have you noticed that your lower jaw has permanently advanced? Like, has it changed the shape of your face? Has it done any like myofunctional therapy on you?
None at all. It's been fine. Because it just does it overnight. It doesn't advance it forever. Now, it does need to be monitored by a dentist, and I do have a dentist that monitors it. But no, these things help more than they cause problems.
Okay.
But, the same is true with C-Pap. Someone uses a mask to help them breathe during the evening. I have seen skin breakdown or rashes. Some things work for some people. Other things other people need other types of treatments.
Yeah, I was going to ask you with C-Pap versus oral appliance, which one is easier for people to use and continue to use?
C-Pap by far is the gold standard. The dental devices, however, have better data in terms of compliance and preference. Now, having said that, C-Pap is appropriate for all sleep apneas. The oral appliances is more pertinent for mild sleep apneas, or sometimes mild to moderate. They're really not indicated in severe sleep apnea unless someone has really failed C-Pap. Then reducing the severity a little bit is better than continuing with a severe sleep apnea.
And I guess there's some people that use both, right?
I think the use of both is underutilized, and the role for using both, let's say both at the same time, okay, is if someone has a really bad sleep apnea that they need high pressures and they're having problems tolerating it, moving your jaw forward while you have the C-Pap on helps reduce the amount of pressure that they use. So that's one way. Now, another way is sometimes people alternate. And yeah, I do have patients that they are comfortable with their C-Pap, they like it, but if they travel, they just use the dental device. Or I have one patient that's a bachelor, he loves his C-Pap, but when he has a honey who stays over, he puts the thing away and he uses the dental device when he goes to sleep.
And, if there is such a thing, on average, how much of an improvement do people experience, and how do they express the improvement to you?
They express by just saying, hey, it's helping. Sometimes we can monitor people on Fitbit devices or other devices. And typically the other thing that we do is that we repeat a study on the device, and we make sure that it is improving so we can get that concrete information that it is.
And for you with the oral appliance, I mean, you noticed that you were dreaming more, which sounds like your REM sleep may have been less interrupted. But, were there short-term effects and then long-term effects? Things you noticed immediately like that, and then things you noticed after, let's say, a month? Like, a little bit more about your experience, if you don't mind.
Yeah, so my concentration definitely was a lot better when I started using it on a regular basis. And then, when this is not unique to the dental device. When I do C-Pap on patients and I do sleep studies on them and I put the C-Pap on them, I see something called REM rebound. And yeah, with the sleep apnea, they've had fragmented REM sleep and less REM sleep, and then all of a sudden now they're breathing. In that first night in particular, they hit something called REM rebound, where they may get a very significant amount of increased REM. And that's actually what I experienced. That first night I had a lot of REM rebound. Now, I still dream and I still go to REM, but you notice it in particular that very first night. It's like, whoa, that's what I've been missing.
And Like, would you characterize your experience as a massive improvement or just a slight improvement?
No, I would say, it's a significant improvement. And over time, as I've been dreaming more, I've actually learned the concept of lucid dreaming, which is the ability to recognize when you're in a dream, which is it's been a lot of fun and was definitely a different talk for a different day.
Very cool. What do you see as the I know I asked you this, but I'll ask you in a different way. What does the near-term future of sleep medicine look like? Is it again just more awareness, more adoption of solutions, or again, is there new technology that you've also heard about that you think will make a big difference?
I think new technology is always evolving. In regards to C-Pap, the technology is the same as it was 20 years ago, but what's different is the comfort features, so new mask, new expiratory pressure releases. There's always new features that are being made to make it a little bit more comfortable and tolerated. There's also some implantable devices, kind of like a pacemaker that stimulates the upper airway. That's going to be a technology that's going to evolve over time to help treat sleep apnea. And then, there's always going to be a role for the sleep lab, but there's also home sleep monitoring equipment that are in evolution as well. So one thing that people have said is that more has been learned about sleep over the last 10 years than we've known over the previous 100. And I believe that to be true.
Yeah, and one more thing I want to ask you, just in brief, about children. When parents bring children to you, how does that happen? Is it that the child's just acting up and the parent somehow figures out that they have a sleep problem, or is it that the parent has a chance observation of their sleep and notices they're snoring or something else is going on?
All of that is correct. So sometimes there's neurobehavioral considerations and they want to rule out sleep apnea or periodic leg movements of sleep as a cause of it. Other times I hear, something that really brings them in a lot is actually something called behavioral insomnia of childhood. And what that is, kind of sleep avoiding behavior, and the patient ends up in the parent's bed, and I do a sleep study on them, and they're like, I'm like, hey, it's normal, that's good. And they're like, but how come he does this? How come and it turns out that patient's always staying in the parent's bed, so because, they have primary snoring. And that could be normal for a child, but because the patient's in their bed, that's how it was brought to attention. So sometimes there's some real sleep disorders that we can find. Other times there's some behavioral considerations that are disrupting the parent's sleep while the sleep of the kid is fine.
Okay. Any other fundamental differences in kids versus adults that you see in how you approach them and helping their sleep, or what, maybe the symptoms they have, or, what it does to them?
So another thing that I work with a lot is a mindfulness-based stress reduction and relaxation training. And in adults, that's more of a formal practice. In children, it's more of a creative, imaginative practice. And that's actually the basis of my book, The Magic Ice Cream Palace. It's a little story about a kid who's going through an ice cream palace, and you captivate the kid's attention with that. And by trying to help the kid warm certain parts of the body, we bring our awareness to that. And essentially what we're doing is we're doing a body scan meditation. So I do that in a creative way. In an adult, you would say, pay attention to your feet, and feel them relax. In a child, you're like, ooh, you have hot chocolate boots going through the Magic Ice Cream Palace making chocolate chip ice cream. So one fundamental approach is, adults, you give instructions, children, you give creativity.
Yeah. Well, it sounds pretty cool. The adults could use some creativity too.
I've had a lot of adults read the book and say, God, I feel relaxed. Even the children's book, they're like, thank you.
Very cool.
Cool.
Well, all right. So, I know I've read you all over the place in the sleep world, but I figured, all right, we'll do a grand tour. What's the best way for people to find out more if they suspect that themselves or their spouse or their kids are having sleep issues? And, what areas do you serve? And if they're not local to you, what can they do?
Of course, you always say go to your primary care physician and let them know. But remember that I said many primary care physicians don't always know a lot about sleep. So another thing that you could do is you could find a locally accredited sleep center. And that, you could do with Google and American Academy of Sleep Medicine and find an accredited center. So healthy sleep, healthy life. 2020 is going to rock.
Excellent. Jose, thanks for coming on the call. I appreciate it.
All right, my man. Be well.
If you like this podcast, please click the link in the description to subscribe and review us on iTunes.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.